Thank you for coming. Ruth Myers here. Our topic for the discussion today is one that I get asked about a lot. In people that we know, people we work for, or other people that we know that communicate without using any words, they don't sign, they don't speak, they don't write. How can we figure out what's going on for them health-wise? Fortunately, and I know y'all have heard this a million times, everybody communicates. And if we become sort of disciplined and diligent about looking at all those nonverbal signs and symptoms, we can often get information that can guide us in the right direction to understand what a person's going through. I think that the other very, very significant point is not uncommonly, well, you'll see it here in a minute, not uncommonly, the people who know the person the best already know what's happening. They just have different words for it. How can we help encourage those people to say what they're thinking? If any of you have already had the seminar about trauma-informed supports, and the fella that had BCBA services for 10 years, and it was his random, very knowledgeable direct support professional who noticed that his urine smelled funny. Those are the kinds of observations we want people to feel comfortable sharing. So we, as a circle of support, circle of people trying to help, can use that information and put it all together to understand a person better and produce a better quality of life. But let's start with a discussion. This is a little girl in 2010 who I met accidentally. Her mother was sent to me because I'm a psychiatrist to say, my daughter's pediatrician said I had to come here, or he would call Child Protective Services. And this is, I think, at the extreme of what we hope doesn't happen, which is this little girl, according to her mother, had hallucinations, detached episodes, spacing out, episodes of unexplained hyperactivity, untestable intellectual ability. That is, she couldn't even engage with the testing, loss of speech, intermittent loss of gait. And the pediatrician, the same one that was going to send mom to Child Protective Services, said this is obvious Rett syndrome. And as you probably remember, Rett syndrome is a degenerative disorder that typically is fatal when in the person's 20s. And there's genetic testing. There's ways to test for Rett syndrome, but this pediatrician was already on a crusade that this is Rett's, the mother's got Munchausen's by proxy, and that's that. And sent her to me on the condition that you have to see a psychiatrist or else. So the mother, who, by the way, neonatal intensive care unit nurse, not a medical lightweight, right? She had some specific speculations. And I think that one of the first places we start is, and I ask this question in every consult, you all have been thinking about this person for a long time. What do you wish somebody would look into? And often the answer is in that discussion. So Marissa's mother wanted her to be evaluated for pediatric autoimmune neuropsychiatric syndrome. She wondered if she didn't have a systemic yeast infection. Is that a big deal? Does that affect pretty much every function of your body and brain? Oh my, yes, right? Some kind of lupus-like syndrome, and some kind of paroxysmal episodic neurological disorder. The options would be something like migraines or partial complex seizures or some other disorder where spells occur out of nowhere. So those were mom's very specific speculations, and she had said to the pediatrician, I want this stuff checked out. And the pediatrician's response was to send the mother to a psychiatrist. How many times have we seen this pattern in the people who we support who are complicated? Is that parents or other very caring, knowledgeable people are written off. It's not right, is it? So these were her speculations. Now I have to mention something. I have permission to show people's pictures, but I don't have permission to have other people show those pictures. So I've done some cropping to disguise identities. So in case you're wondering, do you normally cut people's heads in half, Ruth? No, I do not do that. But for the purpose of a videotape presentation, I do need to disguise people's identities. But I do have carefully obtained permission to show their pictures. This is half of Marissa's head. And as you'll notice, there's a very interesting, very worrisome, splotchy looking rash there on her face. The pediatrician was on such a crusade at this point that he tried to say that the mother had manufactured this rash. So the mother, being pretty much undaunted, sent Marissa to live someplace else for a while with trusted family and stayed away from her so she could document, no, this rash came spontaneously. Mother didn't create it. So what's the appropriate next step? Should we investigate each one of the things that her mother thought she might have? Or should we just go one thing at a time? Because after all, there's this idea in medicine that each person is only issued one or maybe two unusual conditions, right? Rare medical problems. They don't occur in ones or twos or threes, according to some experts who believe you're only issued one at a time. Is that how it really is for the people that we support, people that have severe long-term treatment-resistant activities of concern? It's almost never the case, is it, that people only have one issue going on. So one of the first questions that gets asked is, well, in what order should we investigate these medical possibilities? And the correct order is we investigate all of it as quick as we can. There's no priority. They all are important. Failure to investigate and identify one active condition will make it so that the treatment for everything else won't be very helpful. So that's why we have to do it all as quick as we think of it. Of course, we all know that there's tremendous delays, and we may end up doing things in a sort of a sequential order based on how fast we can push the system, the healthcare system, to react. But we should at least make an initial run at it all at once as fast as we can. So Marissa was ordered to have a whole, what's that technical term? A whole crap load of tests, which were ordered by me because the pediatrician had just decided that I must be out of my mind too, to go along with all this stuff, the mother said. Long story short, Marissa was then treated for PANS, exactly what her mother thought she had, a systemic yeast infection, which her testing proved that she had, Sjogren's syndrome, which is an autoimmune disorder in the family of lupus, and she turned out to have partial complex seizures. Mom only got it 100% right. So did it matter? This is the other piece of pushback we sometimes get is, well, sure, you can identify all these unusual conditions and you can even treat them, but does it make a difference in a person's life? Remember how Marissa was. Untestable, incoherent, barely able to walk from time to time. In 2023, Marissa is in remission of all symptoms. She reads, talks, and writes. Her best friend is her epilepsy assistance dog, and she loves to dance. And she's getting ready to graduate high school now. So I guess it does matter. She's one of thousands of examples that we could talk about. The importance is that so many times when people try and raise a healthcare concern, if it's the least bit unusual, exotic, complicated, there's often pushback because it does take a little more time and a little more work to figure this stuff out. But the thing we can always keep in mind is that it is definitely worth the person's while to check it out. It's not just, oh, what do people say? Oh, it's not just academic interest. No, that's not the case. It really does make a difference for a person's well-being. So when should we start to get very, very curious about the possibility of a new or long-standing untreated health problem interfering with a person's health, behavior and function? Well, the first one is that a person stops getting well or they stop going forward with their life. And it's important to emphasize this because there's still, unfortunately, a mistaken idea that people with developmental disabilities inevitably deteriorate and die young. And some people think that's the natural course of having a developmental disability. That is, in fact, not the natural course of a developmental disability. It's the natural course of medical neglect and can be reversed with diligent health care. If a person seems to, making air quotes, I'm mentally making air quotes, okay? If a person seems to need more than 2 drugs to treat any one condition, that usually means we've missed something else that's making everything harder to treat. Residual physical signs or symptoms. Marissa had that rash. That rash could not be explained by the tentative, disproven diagnosis of Rett syndrome. Couldn't be explained by anything known about her. So even if it didn't hurt, even if it didn't itch, it's still an incredibly important clue that we can't ignore until we really know what it's about. If people are being required to take toxic doses of medicines to control their hallucinations, seizures, what have you, that usually means, once again, there's something else going on that's making their health problems a little harder to treat. And the situation where a person is doing really wonderful, and all of a sudden, without any obvious explanation, all the stuff that's been successful for that person stops being successful. That often means something else is cropped up. So what are we talking about in terms of some of these very specific clues that might help us understand a person better? We need to go beyond what I call the self-stim hypothesis. People will, in fact, I see it written in records even in 2023, people talking about people who have interesting gestures or movements, and they call it self-stimulation, as though that explains it. In fact, there's an imaginary word that I've seen written called stemming. He was spending the afternoon stemming. And it's a roughly equivalent term, the way people use it. But if we just skate past that form of communication with a vague descriptor like that, we'll miss what the person's trying to tell us. When can we safely just ignore the movements, the rocking, the waving, the headbanging, the whatever it is? When can we ignore that stuff? Pretty much never. It's all communication. If we replace and supplement the stimulation the person seems to be craving, and it's still present, or something much more intense takes its place, then it's pretty likely that the person is communicating, and we need to know what they're saying. We could ignore these movements, probably never, if we're talking about people with significant complex needs. Some people would say, if the person's life is absolutely perfect, then whatever they're communicating is not something that is lights and sirens, we got to understand it right now. However, we still at some point do need to make a commitment to understand what people are trying to tell us. One of the ones that I still hear from time to time, maybe you've seen this too, people are described as having high pain tolerance. Right? Anybody, I know sadly in almost every seminar where there's people present, at least one or two people will say they took somebody to the emergency room with a broken arm, and some healthcare professional said, well, since they have a developmental disability, they don't really feel pain, right? And don't give them pain medicine. How many of y'all have had an incident like that lately? Sadly, that absolute wrong misconception is still out there in some quarters. People do not have an innate high pain tolerance due to a disability. How is it that people develop a high tolerance to pain? Well, the answer is practice. People that have a high tolerance to pain typically have medium, long, or extra long experience with being in pain a lot and just having to suffer with it. So the vast majority of the time, this implies the person is experiencing or has experienced fairly severe pain and not had any way to have it relieved or even recognized, and they just cope with it. Now, you remember from other seminars, that isn't a good thing for a person's health and well-being, right? Untreated pain produces a lot of medical complications, which we talked about in some of the other seminars in more detail. Every now and then a person doesn't seem to feel pain because they have neurological damage producing an insensitivity to pain, but that is almost unheard of. In 35 years and more than 10,000 consultations, I might have seen that twice. So it's always important information in terms of understanding what a person copes with now or has coped with in the past. Another one that is a really important maneuver or gesture, and if we understand it differently, we can offer a lot of help and relief, is people with their heads cut off. I'm kidding. This is identity disguise. People that jam their fist in their mouth and most of the way down their throat. For years, decades, this was described as a neurologically based behavior, sorry, air quotes, couldn't help myself, of a person who's immature doing something like a baby would do it. It was supposed to be symptomatic of developmental delay. This is just an infantile activity that's preserved in this person with their developmental delay or disability. It's not true, is it? And Steve, my much better half, the behaviorist, talks about stories of people that would jam their fist in their mouth down their throat, and they had to come up with all kinds of wild, creative ways to try and replace that with something that did not end up with damage or injury to the person's skin and their hands and so on. So what is, in fact, the most common reason why people jam their fist in their mouth and sometimes all the way down their throat or most of the way? The answer is that they're trying to self-manage gastroesophageal reflux, which is, as you know, the thing where the stomach acid washes into the esophagus, right? And the way the nerves run, when that's significant or severe, people feel like they're choking. They feel like they got something in their throat. And so they will respond to that by jamming something. Sometimes people will try and get the same sensation by partially swallowing wads of fabric or other stuff to soak up and manage that feeling of choking that comes from reflux. Now, is gastroesophageal reflux, is that a big deal? I mean, can that cause problems? Hang on. So I was working in Colorado back when dinosaurs roamed the earth, and we got a guy referred to us from out of state. Now in Colorado, we embraced the no mechanical restraints, no holds, no seclusion standard of care really early. But this guy came from a state where they hadn't done that. And he had this problem. He was 18 years old. He was an angel. Most of the people that I see have a history of quite a bit of violence. So to have this 18-year-old snugglebug angel come visit us was kind of cool. He came from this other state where, to keep his fists out of his mouth, they had put splints on his elbows. And he didn't fight them. He didn't argue about much of anything. He was just sweet as could be about the whole thing. And they said, well, since he doesn't mind, and since you guys are supposed to be our state experts, could you just give us a special pass? Because, look at how good the skin on his hands is. He hasn't injured his hands in years and years, and all it took was these little splints on his elbows. Think we ought to do that? Well, if you've got, and I asked his mother who was there, so did he ever get tested for gastroesophageal reflux, the most common reason why people get this particular activity? And she said, well, yeah, he was diagnosed with that when he was a baby. Doesn't it just go away? Does gastroesophageal reflux just go away? Well, maybe, but he'd wanted to jam his fist in his mouth since he was an infant, and that signal never went away. So if you've had gastroesophageal reflux and it's not been treated for 18 years, what do you get? Well, the first thing is you get a bunch of ulcerations, right? In your esophagus from all that washed up acid. And by the way, does gastroesophageal reflux happen more often to people with intellectual and developmental disabilities? The answer is absolutely yes. It's much, much more common amongst people with intellectual and developmental disabilities. Well, so first you get ulcerations. What do you get next? You get something called Barrett's esophagus, which is an injury to the lining of the esophagus. And then if you still don't get treatment, what do you get? You get esophageal cancer. And this 18-year-old angel snugglebug already had advanced esophageal cancer when we met him, and he was dead in 6 months. To me, he teaches how incredibly important it is to really listen to these communications and not just try and suppress them. A few other things. Sometimes people will jam a fist in their mouth when teeth are coming in, when their wisdom teeth are giving them trouble, when they're having a little more trouble with asthma, or when they feel sick to your stomach. But almost always this means reflux. And it also, by the way, tends to mean reflux even when babies are doing it. It's typically not a neurologically based primitive mouthing behavior. It's typically related to reflux or allergies. How many of us know people that do this? They put their hand in a wedge and bite down, right? Often has been, in my experience, dismissed as an autistic-like behavior or a genetic behavior due to Fragile X syndrome. Well, now wait a minute. What do people with autism and people with Fragile X syndrome and many, many other people, depending on where you live, have in common? More allergies. Well, it turns out the vast majority of the time when people are biting down the side of their hand like that, jam it all in their mouth and bite down, it has to do with their sinuses, because it opens up the sinuses a little bit if you bite down hard enough. Or the eustachian tubes, those are the tubes between the ears that drain into the sinuses. As you probably remember, people with Down syndrome typically have flat rather than round eustachian tubes, which are much more likely to get inflamed or blocked by allergies. So the bite down gives a little relief of that as well. Sometimes people do that when their wisdom teeth are coming in, or if they have other dental problems. And sometimes people do that because their hands feel funny. But typically, if their hands feel funny, it's more like biting on fingertips. But it could be either one. So, this is one we can all try together if you like. People biting their thumb or some other hard object between their upper and lower front teeth. Now, we can do this together if you like, even though I can't see you. Tuck the tip of your thumb under your front teeth and press up. And tell me what you feel in this part of your head. Well, most people notice that when they do that, or when they stick their thumb in further and press up on their hard palate, they notice that their sinuses open up. Again, it's another one of those signs, thumb sucking or biting on the fingers, on the thumb, or pressing up against the hard palate had, for many people, been dismissed as sort of an anxiety-related habit or a neurologically based habit, and that's, of course, not impossible. But the vast majority of the time, it's a person who has sinus allergies, blocked up eustachian tubes, or asthma, trying to open up the breathing apparatus. Some of the other things that can go along with that, can be an indication of that, is bruxism, which is the people that grind their teeth at night. Again, often attributed to anxiety, and reasonably so. It can be the cause, but other causes can include sinus congestion, people with different forms of sleep disordered breathing may have also accompanying grinding of their teeth at night. And so the mouthpiece can be helpful to protect the teeth, but if it opens up the breathing apparatus, that's even better, if that's part of the reason. People also sometimes do this if they have like one or two fingers that hurt for some reason, or they're itchy, or they're numb. Uneven seat. People that will only sit on part of their butt. Sometimes this is dismissed as somebody with ADHD or inappropriate seating behavior, non-compliance, not seating. And this is, unfortunately, some of the stuff I overhear when I'm eavesdropping on Steve's CEU courses for applied behavior analysis, is one of the kinds of activities that, in fact, behavior analysts go to work trying to change. People that walk on their toes, people that sit on only half their butt in the chair, and therefore do not look like they're really participating and learning, hand waving, tugging at people to communicate. Those are some of the things that some behavior analysts try to extinguish. But I think that if we look a little closer, there may be some information there. For example, people that just won't sit up straight, won't sit at all, or will only sit part of their backside in the chair. This can be an indication of hip pain, genital or rectal discomfort. It can be a clue that the person is experiencing ongoing abuse, typically of a sexual type, and can also be a clue to what are called body memories, which is when a person feels part of the sensation of the previous trauma without necessarily pulling up a conscious memory of the trauma. So this slide, it doesn't really exactly go. I just think it's kind of silly. It says the guy with the test tube is at the door, and the guy answering the door says, "It's just that I've never heard of a sperm drive before." Actually, it kind of sort of goes. There was this guy that was referred, 78-year-old man with Down syndrome, who was referred for evaluation of new onset perversion. I'm like, a guy who can create a new perversion at 78 is a guy I must meet. So we were all jazzed to go meet him, but sadly, he was not having a good time. And sadly, if it really was a perversion, he'd be having a good time, but he wasn't. It turned out that he was involved in a sequence of activity where he would sit on the toilet, masturbate and defecate and howl in agony all at the same time. Now, since this had been kind of described as a perversion behavior, this had been going on for a year, and he'd been getting a behavior program to try and get him to quit it for a year, and nothing had changed. So I thought, maybe it isn't behavioral. So you think about it, what is going on with a person's anatomy where they would do that? Masturbate, defecate, and howl at the same time. Elderly person with Down syndrome. Well, what do we know about people with Down syndrome? Prostates typically don't swell, but sometimes they do, because that activity, right? Masturbating and defecating at the same time has the effect, in terms of a person's anatomy, of massaging the prostate. Well, what happens to people with Down syndrome more than other people? Intense infections without fevers. And this man, who'd been dismissed as new onset perversion, in fact had a raging infection of his prostate, which, as you know, is extremely painful and must be treated with high-dose intensive antibiotics. And he finally got relief. Odd, unpleasurable masturbation is a really important piece of information and evidence to help us understand. For example, the number one cause in men with odd, unpleasurable masturbation, where they really hurt themselves, tends to be an inflammation or swelling of the prostate. Urinary tract or genital infections, rectal injury or infection can cause people to have odd, unpleasurable masturbation. Parasites, in this particular demographic, particularly for people who have an institution history, we have to be ready for some health problems we thought we would never see, including late-stage syphilis, late-stage untreated gonorrhea, and some of the old reports. You'll see that a person maybe in their teens or 20s got diagnosed with gonorrhea, and it was left untreated on purpose because they thought that turning the person sterile with this illness was somehow a good thing. And those conditions, they just go on, don't they? They cause all kinds of pain and discomfort, and certainly long-standing infection with gonorrhea can affect a person's whole body and from head to toe. We also, of course, need to be ready for repetition phenomena. There was one gal we worked with where she had a masturbation where she would use a sharp object to cut, it was a razor blade. It wasn't just an ordinary sharp, it was a razor blade to slice her nipples. That was her masturbation. It was excruciatingly painful. And she wasn't having a good time, but she felt utterly compelled to do it. We looked, turned out that there was a family member that was assaulting her a lot. That person was removed from her life, and the self-mutilating masturbation went away. She also got some other kinds of recovery services. Then some well-meaning person said, well, I mean, he's her father. They should make up. They should make things right. And insisted that they get back together, and she started mutilating herself again. It was originally thought to be some kind of paraphilia, but the very important part of that is that for people with paraphilias, which is the more professional term for perversion, people are having a good time and they don't cause horrible injury to themselves. And at some point when we talk about sexual expression, we'll talk about paraphilias, which are often just a really harmless and interesting part of a person's life, not something to fight with. And the distinction is that do people have a better life, and do they enjoy the activity when they have this mode of sexual expression, versus the people we're talking about here who hurt themselves and feel a lot of pain and discomfort, and it doesn't feel good. Odd, unpleasurable masturbation. Waving heads side to side. Something that's often kind of dismissed as a sort of just a stimulation activity. But if we think for a minute, what is a person in fact doing when they do this? Particularly if they're, let's say, trying to learn something, and it looks like it's what people will call off-task behavior, but in fact they're not off-task. They're really trying to learn something. What are they doing? What's going on there? Well, it turns out the vast majority of the time, people are trying to supplement their visual field. They have some sort of illness or injury that has altered the capacity of their eyes to perceive the entire field in front of them. And there's a lot of real estate that could be involved with that. Anywhere from an injury to the back of the head, to a tumor in the pituitary gland pressing on the optic nerves, to an injury to the retina, a detachment of the retina or other injury, to gunk, that's a technical term, gunk in the eyes, and cataracts and everything in between. A lot of real estate to look at when a person is doing like this when they're trying to concentrate. It can also be something people cope with vertigo by waving their heads side to side, although people more commonly find themselves compelled to swing on a large swing or just go to ground and clutch the floor. Vertigo, as you know, is a sensation of wobbliness, a little like dizziness, but not exactly the same. Or it could be somebody whose head's on a swivel because of hypervigilance. What's going on around me? And that looks qualitatively different. People typically are anxious and they react to every little nuance change in their situation. Not uncommon in people with post-traumatic stress disorder or other types of anxiety or trauma spectrum conditions. This is a very important finding that I like for people to kind of glance at. Look at this man's fingertips. What you notice is that his fingernails, are no longer flat. And there's a divot between where the skin of your fingertip joins the fingernail, the cuticle area. There's a divot there under normal circumstances. If that divot goes away, and eventually over time the nails puff up, like you see in this man's fingertips, that is something called finger clubbing. And why do we care? Finger clubbing can be the first warning sign that a person has lung problems, heart problems, circulation problems of other types, sleep apnea, and a whole heap of other stuff that interferes with people getting their circulation to the tiniest blood vessels. The fingertips start to starve for oxygen, and that produces inflammation. It causes those tiniest little blood vessels in the fingertips to get inflamed and to puff up and eventually puff up the fingernail. This man turned out to have two issues that were producing these findings. First, he smoked cigarettes one after another, 3 or 4 packs a day. And in fact, the reason he was seeing a psychiatrist was that he was getting into trouble because he had to steal them because they're really expensive. And secondly, when the clubbing in his fingertips went from kind of mild to really severe was when his lungs started to fill up with cancer. So earlier detection is better than late detection. And this is something any one of us can look and observe going on with a person. Well, why such emphasis today? The number one cause of death in people with IDD is lung problems, closely followed by heart problems and infections. And many of those can be detected much earlier if we pay attention to the person's circulation in every part of their body. Walking on toes. Years and years ago, people used to say, well, this is just a symptom of autism. And in fact, they used it as a diagnostic sign. So-and-so walks on their toes, so we're pretty sure they have autism. Doesn't really come out, though, when you see lots and lots more people. Turns out there's more to it than that. Number one, it may or may not have anything to do with autism. But what it does have to do with is arthritis in the hips, ankles, or knees. It can also be a way a person copes with sensory integration issues. And who are the people at risk for sensory integration issues where ordinary sensation is painful or confusing? And one of the most ordinary sensations of all is the feeling of your entire foot being on the floor. For some people with certain chromosome conditions, they will feel as though they're stuck to the floor and can't move and the only way to fix that is to walk on your toes. Well, who is vulnerable to having those kinds of sensory integration issues? People with Fragile X, people with other X chromosome conditions, Turners, Noonans, Klinefelters, people with autism, people with other kinds of sensory integration issues, such as individuals with Williams syndrome, people with Rett syndrome in the middle phases of how they change. So walking on the toes is another thing. I don't think we should fight with people about it. We should just learn what it means for that given individual. We've all known people that do this, right? Rocking. Intense, preoccupied look. And for months, years, decades, millennia, that was unfortunately dismissed as that's just something that people with severe and profound developmental disability, they just do that. It's part of having the disability. And in fact, it means quite a bit more, doesn't it? When we see somebody that's doing this kind of intense rocking with this preoccupied expression, it almost always means that the person has visceral pain. Something from here to here is in pain. It also is a way people cope with headaches, depression, or severe anxiety. Every now and then, I'll see this in people that are having intense hallucinations that they can't shut out any other way. Another symptom where when we interrogate the symptom, we learn so much more about what a person's experiencing. How about people that just won't sit? Their attention span seems to be measured in nanoseconds, and they're hyperactive, and they never settle. Most of the time, people think, well, this is probably ADHD, attention deficit hyperactivity disorder. But it turns out in our research that the most common reason for that is a side effect of certain psychotropic medications. It's also a side effect of certain medicines that are used for nausea. So this can come out of the blue as purely a medication side effect called akathisia. What are the medicines that can cause this? Well, Risperdal, Haldol, Invega, Thorazine, olanzapine, Zyprexa, Seroquel, Compazine, it's a nausea medicine, Inapsine, another nausea medicine, Metoclopramide, which is a stomach medicine for people that have difficulty with esophageal function. Reglan is the other name for it. These medicines all carry a risk of causing akathisia. Now, can this be a big deal? Akathisia, the side effect of akathisia? And of course, the sadness is people that have akathisia are often given higher doses of the medicine that's causing it to try and settle it down. It of course, is not very effective until the person is basically asleep. But how uncomfortable is akathisia? People who can put it into words describe it not only in the outside, that can't get comfortable, can't sit still, akathisia. I'm sure you've heard the translation literally is dancing legs. The legs just can't get peaceful or comfortable. A buddy of mine was an expert witness in a case where the guy's akathisia, internal akathisia, where they feel like their stomach, their esophagus, their lungs, their diaphragm, they're all wobbling like this. The person was so miserable from this that he rolled up a National Geographic, that's a magazine for those of you that were born, in the last 20 years or so, rolled up a heavy magazine and jammed it in his throat and ruptured his esophagus and died as a way of trying to manage this feeling of akathisia. So it can be quite severe, incredibly miserable. And it's treatable. There's a bunch of different ways to treat it. So if we can recognize it as a medicine side effect and not just stay with the first idea of attention deficit disorder, we may be able to save people quite a lot of misery. Other reasons people have a hard time getting comfortable, sitting still, reasons that immediately come to mind. I find it interesting that akathisia in our evidence base turned out to be the top of the list. The others will not surprise you at all, right? Anxiety, depression, back pain, other pain. Some people try and manage pain with excessive amounts of exercise. They try and just drown themselves in their own personal endorphins. Doesn't always work, but many people will try. And sleep deprivation. Some people will become very hyperactive and restless as a way to manage after they've been sleep deprived. Whipping the head forward. We've all known people like this, right? They whip their head forward. Well, is there something important about that? Is there a life-threatening orthopedic problem that can be signaled by this activity? People that seem to be whipping their head forward, trying to get their spine to line up differently. Is there a condition like that? It's often accompanied, for example, with people that are intermittently incontinent. They intermittently walk with their feet wide apart. Is there a condition like that? Well, of course there is. It's called atlantoaxial subluxation. And what that means is that the top bone of the spine, where it hooks onto the bottom of the skull, as you know, that's where they hook together, and there's this little doodad that goes down the middle called the spinal cord. And if these two bones slip, that puts pressure on the spinal cord. And if the looseness is too severe, they'll slip, cut the spinal cord, and the person will die instantly, and there's nothing anybody can do about it. So atlantoaxial subluxation is a big, hairy deal. Children with Down syndrome are screened for this, and I contend that people should be screened for it their whole lives, particularly if they develop any symptoms, because the risk of atlantoaxial subluxation increases with age if you have Down syndrome, Fragile X syndrome, or any of the other conditions that cause joint laxity. People also would do this as a way to cope with headaches and dental problems. But the lights and sirens thing that we got to be really aware of is the possibility of atlantoaxial subluxation, and people will need to get the x-ray. There's a specific type of x-ray. It takes 5 minutes, and we can get the answer. All right. Quick thing, how did this happen? How do you suppose it happened that this man chewed off half of his lower lip and part of his chin skin? Why did that happen? I bet you all know, because you all have tried to help people avoid this. This man had a cavity and nobody could get him into a dentist. And he kept chewing and chewing and chewing till he tore off part of his mouth. He was in the hospital when this picture was taken. He eventually developed gangrene and lost most of his lower jaw, all because he couldn't get in for a prompt dental appointment. So when you find yourself ranting and raving, know he needs to not wait. Know he needs to get in right now. Be assured you're doing the right thing. Left-handed or fingertip-only handshake. You hold out your right hand, the person comes back like this with their left hand. Maybe their right hand's over their chest. Maybe it's to the side or in the back. Why do people do that? Well, I've heard that described in neurological or maturity terms. Well, they just don't know how to have a proper handshake. Well, that's a possibility. But in the people I've worked with, it turns out to be something completely different. Maybe some of you that have worked in various settings will recognize this right away, is abusive previous settings. That is, in many abusive type settings, particularly corrections, but also some of the more violent, older style institutions, the overture to some pretty severe abuse and assault was a handshake. Hey, how you doing, man? And if you do a right hand to right hand handshake, it's very easy for somebody to pull you down and start really attacking you in all kinds of different ways. So a few rounds of that and people learn to cover up and only give you their left hand. And certainly over the years, I've known many people where my initial handshake got a left hand, and then after they realized I was just a harmless cream puff of a human being, they would let me shake hands with their right hand. When a person does this, I always want to figure out what's happened to them in their previous experiences. Where did they stay? Who can tell me about what their life was like there? Sometimes it's a hand thing, you know. Bob Dole had an injury to his right hand, so he shook hands with left hands. That's not hard to recognize in the moment. So Tracy, 40 years old, she is non-compliant. She's refusing to walk. We know she can walk. She's capable of walking. She's just refusing. So are you wondering, is that her usual jam? Can I say jam? I mean, I know I'm really old and everything, but I'm going to keep saying jam for a while. Thanks. Is that her usual jam? To refuse to walk, to refuse to engage with her life. Yet people immediately jump to she's just being lazy and non-compliant. This is what was going on. I ran out to see her because I knew this was not her personality. This is a broken toe. The people that called me to say that she was being lazy said, "Oh yeah, we saw that bruise. We decided to rub some cream on it." What does it feel like to have a broken bone and have somebody massage it? It's not a good thing, not a good thing. So whenever somebody seems to be refusing, let's all first take a look at their bones, huh? See what's what. And if you see this, it's a broken bone. Get an x-ray and get the proper treatment. She needed a splint, and even the most superficial review of her personality would have said that it's incredibly out of character for her to refuse to do anything. She'd try and do anything anybody proposed. So it was a kind of a off-base accusation to start with. Sudden sitting down. Do we know people that do this? Right? Sit down strikes. Really, really vivid symptom and vexing for people that are really, they've gone out of their way to create this perfect day, perfect lifestyle, perfect schedule, and we're getting ready to go and do it, and she just plunks right down, refuses to move. Sometimes she wets herself on purpose. We know it's on purpose. I mean, it's gotta be. Well, hang on a minute. Does this happen at other times? Well, yeah, it happens at other times. So even when she's on the verge of doing something she loves to do, she plunks down like this? Well, what does that tell you? if it's messing up something she loves, there's probably more to it. Now, is there a condition that we've pondered where suddenly the impulses from the brain to the body that help you walk and control your urine and so on, is there a condition where that can be interrupted intermittently? Sometimes they're fine, other times there's pressure on the spinal cord and people just plunk down. I believe we've discussed a condition of this type, haven't we? And in fact, the sudden sitting down has to do with a lot of different conditions. And when it happens, particularly more than once, in a situation where a person is not able to live their life, again, lights and sirens, this is stuff we got to figure out, right? And when we take the person in for the emergency assessment, I think it's very important to say, we are concerned this person's having a stroke. And the reason for that is that everybody knows about the golden hour, they're supposed to. And they all know they need to get on it to figure it out. And everything else it could be will get evaluated in that same package of evaluations. So heart problems, heart arrhythmias can cause this sudden loss of tone. Medication side effects can cause people to fall down, drop their blood pressure suddenly for no reason. Vertigo and dizziness for a variety of different reasons. Ear infections can throw off people's balance. Atlantoaxial subluxation, that slippage that we talked about between the base of the skull and the top of the spine. Certain types of seizures cause people to just plunk down. And certain types of panic can cause people to lose tone. And the best example on TV was Tony Soprano, who had the kind of panic attacks that caused him to lose consciousness, which led to a really interesting TV series if you're into that sort of thing. But anyway, there are a variety of different, very serious reasons why people plunk down that should be investigated, especially when it's very clear that the person would control the condition if they could. Anybody know people that do this? Right? This is quintessentially one of those activities that is thought to be a non-specific, self-stimulatory, common with people with autism kind of an activity, and indeed, that may be exactly all it is for some people. However, think for a moment. What exactly are you doing when you do this? You're altering the visual field. Well, why would you do that? Are you trying to sweep away something in your visual field? Are you trying to reduce it? Are you trying to strobe incoming light or block certain forms of toxic incoming light? Well, the most common reason we found in our research that people do this is to manage migraine headaches. Didn't have anything to do with autism. It was just people with migraine headaches. Scars on the cornea cause people to do this because of the visual distortions. Cataracts, seizures, glaucoma, and medication side effects were all listed and discovered to be the issue when we investigated people doing this. Pica, right? Consuming non-edibles. Well, this was very interesting when we went through all of our, like I said, thousands and thousands of people and figured out these underlying causes. And how do we figure that out? When we treated the cause, the activity went away. They didn't need to signal us anymore that way. Pica was very, very unpredictable. It really had a lot to do with whatever the person piked. I don't even know if that's a word, but it sounds kind of cool. What non-edible is it that the person is eating? That seems to be the determinant of what's going on that they're trying to signal us about. For example, this was not common, but it did occur a few times. Everything in reach, people that consume everything, objects, plant life, bugs, pieces of furniture, upholstery, basically anything they can get their hands on. Kluver-Bucy syndrome is a very specific lesion in the brain. There's another lesion, a hypothalamic lesion, where if you somehow are injured or you have a genetic condition, the satiety cells in the hypothalamus are missing or vastly reduced, and that can cause this constant consumption. This can also be temporary as a result of extreme deprivation. People that have been subjected to severe neglect, including starvation, usually have a phase in their recovery that involves massively over-consuming pretty much everything. As you know, part of the genetic issue in people with the more severe forms of Prader-Willi syndrome can involve loss of satiety cells. And so those people feel neurologically driven to consume like they're starving, no matter how many calories they've already consumed. It's a very painful condition to live with, much more treatable than you'd think, but that's another discussion for another day. If people pike broken glass, we found that that was typically an effort to commit suicide. You've probably seen this too. We found that in many settings, people underestimated the capacity for people with severe or profound developmental disabilities to become suicidal. And they terribly underestimated their capacity for completing suicide. People were very inventive. They typically found ways where they didn't think they'd be discovered. One of those was to simply inhale stuff and asphyxiate themselves. Another was to swallow broken glass and bleed to death. Very, sounds to me pretty excruciating. And the misery leading to that type of suicide sounds pretty horrific as well. People that ate feces, their own or others, or animal, typically that was an issue of post-traumatic stress disorder. There is a very, very, very tiny subset of people with schizophrenia who also have coprophagia, which is the eating of feces. Even people with coprophilia, which is people that get pleasure from feces, usually are more interested in the aromas and the textures than they are with the actual consumption. People that consume grass, leaves, flowers, typically are low on their B vitamins. And sometimes that can be, well, more than sometimes, that can be managed successfully if the person starts to get some B complex supplementation. It's also important, as we talked about before, to make sure we check levels of everything. Because sometimes people they eat plants or things of that nature to try and manage a toxicity. So we shouldn't just offer and supplement people without knowing what's really going on in that person's system. People that eat cigarette butts typically were trying to manage severe anxiety, or they were addicted to nicotine and couldn't get access through the more typical routes. And people that would swallow big wads of things like torn up fabric or other kinds of big wads of stuff, almost always were trying to manage reflux, gastroesophageal reflux, and the sensation of choking and acid that they were trying to get help with. So another topic is people that seem to tie themselves in knots, or they use pieces of fabric or other kinds of tools to tie themselves up. Sadly, this gets misinterpreted as he likes restraints. He likes restraints is a very, very specific subset of people where there's no harm and there's a really welcoming community for people that want to join this safe BDSM community. That's not what we're talking about here. We're not talking about people that get sexual pleasure from the whole BDSM side of life. Bondage, dominance, masochism. In case you're wondering what BDSM stands for. Bondage, dominance, sadomasochism. It's a community, it's got rules, it's welcoming, and it's not unsafe. What I'm talking about here is people that tie themselves into knots in ways that look painful, probably are painful. And usually that's because they're trying to manage something extremely painful. It's not an indication that they like being put in restraints. For example, the most common reason I've seen people, particularly people that choke off extremities, is that they have terrible pain or what's called a paresthesia, numbness, tingling, bizarre feelings of that nature. People with complicated forms of post-traumatic stress disorder may tie themselves in painful knots as part of their overall pain and need for recovery. People who have movement differences, who've been punished for them, will sometimes try and avoid that punishment by trying to restrain themselves. And one of the reasons that, for example, restraint is absolutely contraindicated for most people, particularly for people with Tourette's syndrome, is that the tic impulses don't go away, they build up, and people will end up with broken bones and dislocated joints if they are put in some kind of hold or restraint during a flurry of tics. And people with severe sensory integration issues will sometimes tie themselves or restrain themselves. And to some degree, there's coping. We all know about Dr. Grandin's squeeze machine that she used, but she didn't hurt herself with it. She comforted herself with it. And that's a little bit different operation, totally under her and safety control. Headbanging. Headbanging is never normal for anyone. That does not surprise anybody who's here. Unfortunately, there are still, right this minute, textbooks that are published that say that headbanging is a normal part of a developmental disability. It isn't. Not normal for anybody. It means something. What do you suppose the most common thing is? My thinking when I first started to learn about this is that the most common reason people bang their heads is that they have headaches. Well, why would you do that if your head already hurts? Well, that's because the pain you can control hurts less of your brain than the pain you can't control. It's the way our different nerve networks work in our brain. Chronic pain you can't control lights up a whole network of fibers that connect to way more parts of your brain. The core areas, the memory, the limbic system, all of it. Whereas the pain you give yourself shuts all that off and just gives you a much more manageable, superficial type of a pain. It doesn't last very long, and it's still pain. But when people have confusion about why would you hurt a place that hurts, that's the reason. The pain you can control hurts less than the pain you can't control. But it turns out the most common reason for headbanging, not that I want you to remember this or anything, but the most common reason for headbanging is depression, major depressive disorder, which is in fact the most common psychiatric condition that we find in people with IDD who have complex needs. Major depressive disorder with an agitated or self-injurious presentation. Well, people say, well, Ruth, why is it that the traditional presentation of depression is this sort of slow-moving, sluggish, sad, barely moving kind of presentation? And you're saying all these people that are agitated and destructive and self-destructive and sometimes even aggressive, that their thing is depression? Why are you saying that? And it all comes back to, what is the natural course of untreated depression? Because if a person with an IDD in many systems just becomes sluggish or doesn't sleep too well or loses interest in sex, there's often not much reaction to that. Whereas other people would get recognized and treated for the depression that's going on, it doesn't always happen that way for people with IDD. So, what happens over time with untreated depression? Well, it starts to affect a person's body and mind in all kinds of different ways. Some people will get their heart disease sooner. Some people will get ulcers or colitis. Some people will have accelerations in their conditions like rheumatoid arthritis. Whereas there's a subset of people with depression where the longer they're depressed, the more angry, agitated, hostile, and destructive they become. So I believe this more frequent agitated presentation of depression in people with IDD is happening because we're missing it in the earlier stages. And headbanging is a very common way that people express depression. There's also a bunch of other stuff, not surprising: dental problems, seizures, other kinds of headaches. If you have tinea capitis, you know what that is, right? Candida infection of the scalp, that can make people want to bang their heads. It's a really itchy, yucky, that's another technical term, yucky, condition. And ear infections, as well as mastoiditis, right? That spongy bone that surrounds the ear, that can become infected and inflamed too. And if you just look in the ear, you won't find the mastoiditis infection. That requires an X-ray. So if a person's doing this, and you look in the ear and there's no infection, we may still not be done yet. We might still need to get that X-ray to figure out the mastoiditis. So how about people that stretch forward? They're seated in a chair and they stretch forward like this, right? So, it's not noticed a lot because it's not that dramatic of an activity, but it turns out to be an important clue. We in our traveling team called that the gastroesophageal stretch, where a person's stretching forward to try and manage that reflux pain that we talked about before, where the stomach acid is washing into the esophagus. People will also do that when their hips hurt or their back hurts. So if somebody presents to us doing this a lot, we might want to ask for, Dr. Smith, we're worried about the following. We are worried about reflux, hip pain or injury, or back pain or injury. Can we please have x-rays and evaluation? That's much better than saying, Dr. Schmedlap, we have somebody who's stretching forward from the waist while they're seated. You might not get all the things you're looking for. It's better to come with specific questions. So this is half of Dee's face. And Dee's 36 years old. She happens to be deaf, very, very fluent signer, very fluent communicator. And she was referred for evaluation of hysterical abdominal pain. As you know, if you translate that, that means that somebody thought she had a psychotic uterus wandering around her pelvic cavity. Well, what do you mean hysterical abdominal pain? Meaning that she's using complaints of pain to tell us that she doesn't want to go to work or that she's nervous. All right, so we visit with her, and sure enough, she's got a lot of abdominal pain, and it's happening every month. So the first thing we said was, well, did you go see your doctor? Well, this is a town, one of those tiny little towns where there's like a doctor to choose from. And she went to go see this guy, and he did a pelvic exam, which, what does that tell you exactly? Nothing, except that it might detect if you have trouble with your cervix. There's a lot of other real estate there that's not very accessible to a pelvic examination. But he did it, and his response was, well, you know, these people, especially the deaf ones, yes, I see all of you deaf staff going, oh my goodness. These deaf ones, they like to exaggerate things. So when she starts to moan and groan about this pain in her abdomen, just ignore her. And he literally patted her on the head and sent her out the door. And I said, well, what runs in your family? Is it of interest that her mother, sisters, aunts, and grandmothers all had such severe endometriosis that they all had to have hysterectomies in their 20s just to function? Yeah, I think that's relevant. And can you find that with a typical pelvic exam? No. So we come back to this family doctor, the one doctor in town, and we say, you know, she really needs imaging because you treat all the family, you know, they've all got endometriosis. This is a monthly pattern. She's, miserable. She's much older than her sisters, and they all were incapacitated in their 20s. She's 36, blah, blah, blah. And he said, you're just giving in, whatever that's supposed to mean. If you want to image her, you go image her. Well, all right. I was university faculty then, and University Hospital was way far away, but all right. Come to Denver and we will image you. And the imaging showed just incredible amounts of endometriosis, which, as you know, is the kind of globby stuff that lines the uterus. In endometriosis, it gets stuck all over the person's insides. Outside of the uterus, it gets stuck on ovaries, it gets stuck on everything. And every month it swells and bleeds and hurts. So I'm feeling pretty full of myself because we have smacked down this whole hysterical abdominal pain issue. And I decided this guy can't be allowed to get past this. And so I take the x-ray results and I march myself over to his clinic. I say, you know that gal who you said was just being hypochondriac, the gal that you said was just being hysterical? Have a look, buddy. How do you think he reacted? I'm like, my estimation of his teachability was less than 0. He looked at it, and I'm not kidding. He said, oh my God, I have made a horrible mistake. Oh my God, where's Dee? Where is she right this minute? I need somebody who can interpret for me. I need to see her right this minute. And he went running across town, it's a small town, took an interpreter who could barely keep up, found Dee at her job, dropped to his knees in front of Dee and all of her coworkers and said, I am so sorry. I was so wrong. If you can trust me, and if you can't, I understand, but if you can trust me, I want to be your doctor and help you with this. And if you can't trust me, understand that too, I will find you somebody. And Dee's like, cool. how often does that happen, right? So this doctor, he got himself one of his GYN surgeon mentors, and at his own expense flew the guy to her hometown to help do what Dee wanted was the same operation her sisters had. And I gotta tell you, man, we were swaggering. We were like so full of ourselves. But we made one grave tactical error. We followed up. And it turned out that even though she felt a bajillion% better, the pain wasn't gone. Like, oh man. So if a person still has the same symptom, even though we've fully, completely treated what we think the cause is, what does that mean? We have to go hunting again. So the first thing is we call up the doctor, the one I was talking about, and say, she's still got pain. He said, okay, let's go. And he got her into the operating room right away and, scoped her to check, see what they missed. Well, as I suspected, he was so mortified by his original failure. There was not an endometrioma left in the entire county, much less inside of D. So then we had to start over. Now, wait a minute. Take a history, Ruth. Get more information. What else goes along with this pain besides it happening every month? Well, it doesn't always just happen every month. Oh, well, how old was she when it started? 3. She didn't have much possibility of endometriosis when she's 3. Oh, and she's got this other behavior too. She wants to eat sugar all the time. Really? Yeah, we think she's got some kind of addiction to sugar, because when she eats lots and lots of sugar, she seems really happy. And I went, oh no. Take a good look at her face, and what do you see around her mouth? You see some splotchy stuff. That's another technical medical term, splotchy stuff. And what that is deposits that happen after blood cells rupture after you've had an episode of porphyria. Acute intermittent porphyria is a totally separate condition, has nothing to do with endometriosis, that also causes abdominal pain. So when she had unrestricted access to sugar and she got a little bit of medicine treatment, finally she was pain-free. She illustrates so many things, but not the least of which is that the same symptom in the same person can mean more than one thing. And it kind of stands to reason if you think about all the reasons you might go home and eat too many cookies. Sometimes it's because you're happy. Sometimes it's because you're tired. Same thing with the body. The body may only complain one or two ways about a whole bunch of different problems, right? She finally was pain-free. And I had to, of course, apologize to that doctor because I'd been kind of a swaggery person with him. And we were both right and both wrong. In people who are diagnosed with psychosomatic pain, he's got the hypochondriac like that, depending on who you read, 86 to 98% turn out to have some other treatable reason for the pain or discomfort. It just takes a lot longer to figure it out because the presentations are nothing like the textbooks, which is why we used to call them Med-H clinics, and it stood for Medical Hypochondriac Clinic, which is not a very flattering name. But the correct treatment for people that were thought to be hypochondriacs was regular check-in visits with the physician, where you'd look the person over, see if there's anything different, see if you can figure out something else. And the idea is to avoid, giving people treatments that they don't need that make them sick, or doing too many tests that don't really give you any information. But for the most part, it helps with that very gradual process of solving the mystery. So the current practice of many health insurers to restrict access to direct contact with physicians, in fact, is making a lot of people sicker. And this is part of the reason. Sometimes it just takes time and seeing people more than once. So as we're trying to figure out what a given gesture or activity might mean, how do we do it? What's a procedure? Well, if the person, let's say, hitting themselves the same way all the time, or hitting other people the same way all the time, well, let's look at that body part. What could be going on there? What could be going on that's invisible to us, but maybe we could figure it out with some x-rays or a proper examination? We look at what is avoided. Some people do a thing we call splinting, which is where they tightly compress their chest or abdomen, and that's a way for people to manage pain in the viscera or in the lung cavity. What does the person numb? One gal that I worked with for a long time, she was chewing on the tips of her fingers when I first met her. And when she wasn't chewing on the tips of her fingers, she was trying to choke off the circulation to her hands. And it only made sense because it was absolutely symmetrical and bilateral that there must be something going on in her spine. Well, her treating physicians absolutely refused to image her spine, and her insurance company absolutely refused to use my orders. And we can think of a prominent managed care organization in town that has that policy. So I see her, I offer my suggestions for how to figure this out, and they were talking all about restraints, right? Well, we can just prevent her from chewing on her hands or choking off her hands if we just tie them down. I said, nah, that's suppressing communication. It's absolutely wrong. 10 years later, I'm asked to see her again. By this time, she has chewed off her fingers. 10 stubs down to here. And I say, how about that imaging we talked about? Finally, after 10 years, they found she had a lemon-sized tumor in her spinal cord that was exactly placed to make her hands feel weird, to give her a severe paresthesia, and the only thing she could do to manage it was chew on herself. What is the person numbing? What is the person avoiding with the given gesture or activity? People that tie themselves up to avoid being punished for their tics. People that grit their teeth and stop speaking to avoid being punished for vocal tics or for other vocalizations. If a gesture didn't look too painful, we on the team would try it out ourselves. If it did look really painful, we'd get a medical student to do it. I'm kidding, we didn't really do that. But if a person had a given gesture, we would try as hard as we could to try and duplicate that gesture in ourselves. What does this teach us about that person's body? We also should remember the issue of referred pain. For example, if you've got something going on in your gallbladder or your liver, it might hurt more in your right shoulder than it hurts in your abdomen. That's why if a person's having a heart problem, they may have more pain in their left arm or up in their jaw than they do in their chest. Itching and tingling are nearly as annoying as pain. So if a person is scratching, itching, biting, chewing, itching should also be considered, itching and tingling. And sometimes, this is Josie. Josie is 36 years old when I met her, and she bashed the snot out of my head. She bashed her own head, basically, since she could actually maneuver her head. So however many weeks that is after birth, when she could hold up her head, she started bashing it. And I used to think, well, this is only waking hours, right? She's 36. She's been on every drug that's ever been made, every speculation about what could be going on in her head, right? So even though all of her scans only showed a lot of remodeling of her skull and a lot of thickening of her skull because she'd been bashing her head continuously for 30-something years. And people were saying, well, this is only waking hours. No, it wasn't. She was also bashing her head consistently in her sleep. People were courageously working to avoid tying her down and instead trying to block so she couldn't hurt herself too badly with these head smashes. But nobody had figured out any. We treated her for possible seizures, possible psychosis, possible migraine. We'd imaged her to look for tumors or masses or scarring or infections. We probably, her sinuses were beautifully imaged, her middle ear structures. We looked for acoustic neuroma. We looked for every possible neck up issue that could make her want to bash her head the way she did in such an incredibly persistent, consistent way. And we got nothing. We got nothing. So what do we do next? Do we just let go? Say, we have investigated her head to the limits of medical science in this or any other planet, as far as we can tell. Are we quite done? Yeah, we're not quite done. Because doing this could have something to do with someplace else, couldn't it? At least that's what we guessed. So logic completely failed in us trying to figure out why Josie was doing this to herself. So the next step was to look at her from head to toe. And this is something that rich people do all the time. And so, as my husband says, if rich people are lining up to do this, it's probably a good idea. If they're spending their own money to do it, which is to look at a person from head to toe. Imaging, anatomy, head to toe, CT scan, bone scan. Does this person have a bone mass? Bone masses are extremely painful. Does the person have an autoimmune disorder in some part of the body causing the fluid around the blood to be sludgy? Or do they have some form of arthritis or other inflammation? Do they have a condition like Cornelia de Lange syndrome, which causes people to just have a lot of pain that needs to be treated? Endocrine review, hormones, basically nutrition. People with, for example, beriberi want to claw their skin off. It's a very miserable condition, and so on. Infections, and pretty much anything that can gunk up a person's circulation can cause headaches, lung problems, and so on and so forth. So since she'd waited 30 years to get an answer, we didn't get that much resistance to doing the head-to-toe evaluation for Josie, who'd been smashing her head against things since infancy. And when I met her, I might have noticed that she had something called Costello syndrome, but Costello syndrome had not been published or described when I first met her. That didn't happen until about 10 years later. But if I'd known she had Costello syndrome, I might have looked a little sooner for what she turned out to have which was an intestinal diverticulum. What's that? It was a small intestine diverticulum. It's like having an extra appendix, and hers was swollen. It was very likely that she'd had this basically appendicitis type pain her entire life. And that's why she smashed her head, we guessed. At least when she got an operation to take out that swollen, inflamed diverticulum and her other appendix, the head banging stopped. And stopped for the additional 20 years that I knew her. So let's talk a little about those hallucinations. Another question that comes up quite a bit is, how do you identify delusions or hallucinations in people that communicate without speech? Is there any other way to figure that out? And it turns out that there is. What do I mean by psychosis, right? Hallucinations, delusions, or paranoia. Hallucinations are sensory distortions, right? Hearing things that aren't there or that other people would not say are there. Visual hallucinations, seeing things not evident to others with intact vision. Olfactory hallucinations, so odors. Gustatory hallucinations, tastes in the mouth. Many of you know people, for example, with seizures who get a metal taste in their mouth right before a seizure. That's an example of a gustatory hallucination. And tactile hallucinations, people feeling like there's stuff or entities on them. Delusions are false beliefs, out of the range of possibility and not consistent with a person's culture. Certain spiritual ideas are not consistent with every religious or spiritual culture, but they may be consistent with that individual's culture. For example, is it psychosis if a Navajo man speaks and converses with his deceased relatives on a daily basis? No, that's cultural, that's appropriate. There's nothing psychotic about that. And delusions are considered significant when they cause distress, dysfunction, or unsafe behavior. And the most horrifying example is mothers of newborns that believe that the only way to save their newborn baby is to kill it. That's an example of a postpartum psychosis delusion with lethal consequences if the person doesn't get the help they need. And paranoia is the belief that others think ill of the person and are plotting against them. And it's typically considered to be paranoia and not just suspiciousness if the individuals they suspect are people that are very unlikely to even know they exist or care. Strangers that they just met for the first time. Oh yeah, they're gunning for me. And also reassurance or researching the problem. Well, let's sit down with so-and-so and see what they think. If it's authentic paranoia, people just feel worse. You try and reassure them, they think you're part of the system that's against them. If you try and sit down with the person, well, they're all just lying anyway. Person can't be reassured. So paranoia is a really miserable symptom. Hard to try and align with somebody who has severe paranoia, and easy to lose the alliance. Blended hallucinations and delusions, ideas of reference where the person believes that they are getting personalized messages from the TV or the radio instructing them as an individual to do things. Thought insertion, where a person believes others are putting thoughts in their mind. Thought broadcasting, a person believes that other people can hear their thoughts. And Capgras phenomena, which is a belief that familiar people or objects are not really themselves, but are nearly exact copies. The way this often will present itself is a person will say, now I have 3 pairs of parents. I have the good ones, and then these other 2 pairs of parents, and they're bad ones. That's one of the ways capgras might show itself. Or, you guys took all the stuff out of my room, put something else in there, didn't you? When it's the exact same stuff. So in people that don't communicate with speech, who communicate without speech, how do you guess that they might be having these symptoms, right? Well, what we did was we went to a whole bunch of inpatient psychiatric units and observed people that were in the immediate stages of psychotic episodes. They had been brought in, they needed inpatient care for their psychiatric symptoms. And we just watched them. What'd you do? What did they do gesturally or interactively? And then after they felt better, we asked them what it meant. And we found out some stuff we weren't expecting. So I'll offer you what we found out from that research. The most common thing, of course, we've all seen people do this who communicate with or without speech. It's people looking off to the side at a place that looks empty to everybody else, and they're communing with somebody or something. They're having an interaction with that person, gesturing, nodding. Yeah, that's right. Obviously, it makes you think of the person is having some kind of hallucination. What else could it be? Always got to be aware of what else could that be. It could be an authentic spiritual experience. And there's been some wonderful stuff written on how to distinguish between psychosis and authentic spiritual experience. And if it's terrorizing, it might be part of post-traumatic stress disorder flashbacks. And there's some overlap. There's a kind of a limited piece of real estate in the brain where hallucinations live, and it can be triggered by thought disorders like schizophrenia conditions. It can be triggered by post-trauma conditions. It can be triggered by seizures. And all those things can coexist in the same person. It can also be triggered by migraines. Chemical, electrical, structural, fuel line. Remember, in another seminar, we talked about all of neurophysiology comes down to chemical, electrical, structural, and fuel line. So how about a person who's getting into fights and nobody else can see who or what they're fighting with? Obviously, people wonder about, visual hallucinations of whoever they're fighting with. Something else we have to add, though, to the list recently is some people who are deaf-blind who navigate with sonar and navigate by making certain resonant sounds and certain abrupt gestures. And it looks like they're fighting, but they're in fact navigating as a way of sensing their environment. What else do we find from the original research? A lot of times, if the person had a developmental disability and an institutional history, they were walking us through stuff they'd been trained to do. There was an era in institutional care where behaviorists just taught people to do random stuff that wasn't really productive because they had the technology to do it. There was one whole cadre of people we met where they all had this same behaviorist in the same institution ward at the same time, and they all had this gesture that nobody could figure out. Slap, slap, slap. And we're like, what's that from? And it turned out that this particular behaviorist thought it was adorable to teach people who communicate without speech to demand food that way. And I mean, it kind of works if anybody else knows what it means, right? But nobody did. So volitional rehearsal or repetition of training. Flashbacks obviously are a possibility. And again, spiritual experiences. But again, most of the authorities that know a lot about this stuff say that authentic spiritual experience is positive. It's people are typically not in a rage or angry or petrified. So it's typically probably not a spiritual experience, although there's still, of course, going to always be controversy about that. How about simulated or actual sex with objects or animals not in the person's usual repertoire? Tactile hallucinations and erotomanic delusions are the names for that. People, it was always very, very intense experience for people to sit with you in the day room at the inpatient psychiatric unit and look at you like, don't you see? Because they themselves are believing that they are having sex with some entity at that moment, an animal or a demon or something like that. But what else could it mean, right? Sexual activity that is self-injurious, just like we talked about a few minutes ago, can also be an indication of ongoing or past sex trauma, right? Unusual, complex partial seizures are highly, for some people, highly sexualized. There's a couple of things that can go along with that. People with certain types of partial complex seizures tend to like to write a lot. And if they don't have words or speech, they tend to scribble a lot. And they tend to also sometimes have this highly sexualized aura. And some people believe that that's the reason Tolstoy never got his seizures treated, because he had this intensely sexualized aura and it really drove his writing. And as you know, he wrote a few things that were kind of long. Also, sexual predator activity, it's typically accompanied, though, by stalking, grooming, coercion, or other kind of criminal elements. Typically, sexual predator activity is not just isolated, simulated sex with objects or animals. The other thing to keep in mind, this is for our friends and neighbors with autism, is that there's a condition called objectophilia. And you probably have heard about this, if from no other place than Boston Legal, where people have their most intense romantic and sexual connections with objects. And most commonly, this occurs in people with autism. And most commonly, the sex object is a very interestingly shaped traditional appliance or a computer or some handmade contraption. Whatever it is, it's typically a source of peace and pleasure and not something to give a person a bad time about, right? How about people that are brushing stuff off themselves? And all you see is, you don't see anything that's being brushed off. Bugs are often what people will report. Can't you see the bugs? Bugs that I'm getting off of myself? Tactile hallucinations, right? Very, very common, by the way, in people withdrawing from certain chemicals, particularly some of the more popular current medical chemicals like fentanyl, other opiates, and methamphetamine. The withdrawal can include this sensation of things crawling on you. Now, there's also a very classic form of this in people that are withdrawing from severe alcohol dependence, and it has a cool name. It's called formication. Formication. So you can ask people, have you had any formication recently? Should get some interesting answers, I'm thinking, right? So people are brushing stuff off themselves. What does that mean exactly? Well, it could be tactile hallucinations, and tactile hallucinations happen a lot in chemical withdrawals. Can also be paresthesias for other reasons, numbness or tingling in the hands and feet. It can also be partial flashbacks, which is where people experience some of the physical sensations of some traumatic incident without a conscious memory of it. Very common in people who've been injured by burns to feel like something's burning again, even when there's no heat source or anything like that nearby. Some other paroxysmal phenomena can cause all kinds of different unusual sensations: migraine, partial complex seizures, conditions that produce sludge in the fluid surrounding red blood cells. One of them is more common in people with Down syndrome, called antiphospholipid antibody syndrome. Rolls right off the tongue. And again, those chemical withdrawals. In addition, what about people, we see this a lot, right? People wearing lots and lots of layers. And for people that were being treated for schizophreniform conditions, they often told us it was because they felt like if they didn't do that, their guts would drip out, or their arms would drop off, or the hallucinations would get out or get in. And that was the reason for all the extra layers. However, for people specifically with IDD and people with an institutional history, it turned out to be other stuff, usually. It was a really good method for keeping your stuff in congregate settings. If you're wearing it on your body, it's harder for a person to steal it. It was a learned method for staying warm if the people were sleeping out of doors. And I worked with people in Alaska who were unhoused, and it was incredible in the winter. It was incredibly inventive, some of the strategies that people were able to create to stay warm while they were unhoused in Alaska in the winter. Some people develop this multiple layer thing as a trauma response. It's much harder for somebody to attack you if they have to get through a lot of layers to do it. And again, sensory integration support, people with Fragile X, autism, certain other conditions. That pressure of the multiple layers can be soothing, like Dr. Grandin's squeeze machine. How about people that cover their eyes or their ears, like this? Very commonly thought to signal a person's efforts to suppress auditory or visual hallucinations. However, it can mean a lot of other things too. Fear. When people are scared, they sometimes want to shut out what's scaring them, even if it's not a hallucination. Suppression of traumatic memories, suppression of current experiences, or response to hypersensitivities. As you know, our friends and neighbors with Fragile X in particular often have hyperacute hearing, and ordinary levels of sound are painful, and they want to shut that out. People who put wrappings like sanitary napkins or a ragged bandana with a business suit around their ankles or wrists or ears or other openings, their mouth, their nose. Later on, people told us that this was a way to either keep out the demons, to keep in the hallucinations, or to keep their brains from dripping out of their head. And it was really inventive. For a while we didn't quite understand the men that were raiding the sanitary pad part of the supply closet. But then they explained it to us, and what a miserable feeling to feel like you have to do all that to keep your body from falling apart or dripping out. However, there are other reasons people do similar kinds of things. One is aching joints, especially if they're putting pressure on those joints, keeping warm, and again, storage for people that live in settings where their stuff is likely to be stolen from them. James is a 33-year-old guy referred for intermittent, inappropriate coffee behavior. Sounds like a felony in some state, don't you think? Oh, come on, Ruth. No, listen, this is really weird. All right. Teach me about it. Okay. Every now and then, James, who liked coffee almost as much as I do, he had a rhythm with his support staff where they would make a big old pot of fresh coffee that would be ready basically just as he's getting up. He'd quietly grab the pot of coffee, take it outside, dump it out, bring it back in, and make an identical pot himself and drink it. And other times, this didn't happen. And they knew over time this would progress to where he would not accept a single piece of food or fluid that had been prepared by anybody else. And it got to the point where he didn't even trust the basic ingredients when they came in from the grocery store. And he would start to lose weight and starve himself because of paranoia. He believed his food was being poisoned. And this was an entirely nonverbal way of reporting it, but it would always start with the coffee thing. And if they didn't get ahead of it, it was going to progress to a very painful state of affairs. How about people that glare at people they kind of liked before? A lot of times people's like, wow, they got real paranoid about so-and-so. And they worked really well with that person for a long time. What's that about? And initially, people would often say, oh, that's paranoia, However, unfortunately, in our world, that kind of activity should at first trigger an investigation that something might have happened. Because what are those abuse percentages in people with IDD? Typically abuse by a person in a position of trust. They may have changed their feelings about a person because that person's done something bad to them. So sadly, statistically, that's where we should start. But also be aware of the possibility of paranoia or that a new person is a trauma trigger. One fellow we work with here at STEP, there's a certain demographic of staff member that cannot work with him because they look a certain way and they look very identical to a perpetrator that abused boys at the Fremont School for the Deaf for 30 years before he was finally caught. This employer here at STEP simply does not tolerate being in the same room with anybody that resembles that perpetrator. How about people that wear costumes inconsistent with known reality? Thinking possible delusions, and not just plain dress up or playing around like that, but for example, somebody stealing a police uniform and believing that they have been enrolled in the security, not just expressing a wish to be part of security. Most of the time, this is, it's an expression of a wish. It's not usually psychotic, but we still have to have that in mind. Does the person say they want to do this, or do they believe that this is who they are right now? It could be a manifestation of facts not yet known to others. And what's the most common manifestation of this? People that are becoming more and more aware that they're transgender or non-binary or not whatever role they were assigned at birth. And they may start dressing the part before explicitly talking the part. And somebody said, "You mean that there's people with severe and profound IDD that can't even talk, but they could be trans?" Yup. Absolutely true. And what an exciting time when people have a chance to be themselves. It's just a beautiful thing to watch. People may be explaining history, something that was perpetrated on them before. Often people will be trying to conform to roles assigned to them by people that they esteem. Close friends and family wanted them to do this, so they keep dressing the part. Or an expression along the same lines of another person's wishes. How about people that run in circles to the point of collapse? Most of the time, people thought this meant people thought they were being chased by an unseen entity. However, upon further review, it turned out that that was almost never the reason. The most common reason was that akathisia that we talked about before, that medication, antipsychotic medication side effect that makes it so people are restless and can't get comfortable. People also do this as a form of pain management as well. How about people who are kind of grimacing or wincing, tasting or smelling something kind of nasty, right? Olfactory or gustatory hallucinations. This periodically comes up in meetings when people will be falsely accused of farting or other kinds of olfactory events, smell events. Interestingly, when this occurs in the absence of any other type of hallucination, it's almost always due to something else. And the most common contenders are migraine and seizures. This also can happen with partial flashbacks. And we had one fellow who had a particular type of epilepsy that caused flashbacks, and he loved these flashbacks because he smelled his mother's kitchen. So he smelled baking bread and cinnamon. It was quite lovely, although the seizures themselves were kind of serious. How about the person that examines their food with a lot of suspiciousness, refuses to eat or drink something unless he or she prepared it? Obviously, this could mean the person believes they're being poisoned. However, again, looking back on institutional histories, it could also be a learned coping strategy for people that have been administered medicines hidden in food. Many times people will talk to me about, like, for example, their children don't want to take pills. Well, we'll just hide it in XYZ. And unfortunately, that is not a benign thing. It doesn't work out well in the long run at all. Particularly if the person experiences a lot of side effects from medicines being hidden in their food. So I always ask people to be very, very thoughtful and cautious about this idea of sneaking things into people's bodies, because it does not necessarily end very well. People that hide from previously trusted people. Paranoia delusions, right? It's another indication of that possibility. But, like we talked about a couple minutes ago, this is also something that in this particular demographic, people with IDD, we also have to look very, very closely at caregivers to see if something's bad or something's changed. And then think about trauma triggers as well. So what are some symptoms or activities that are almost never psychosis People shouting and screeching, it's almost never psychosis. People appearing to mumble to themselves, almost never psychosis. Sometimes, but almost never. A situation where a person is very deliberately copying somebody else to get whatever that person got from the various activities. Okay, if I tear my shirt like this and do like this, then I'll get what that person got who did the same thing. Typically, if a person can start and stop the different activities at will and doesn't feel any tension about it, probably not psychosis, but still got to keep our minds open. And gestures that have been clearly taught to the person, like the people that were taught to do this to get something to eat. It's not a psychotic thing, it was something they were trained to do. What are some ways to try and connect better with people who have severe paranoia? Because as we talked about before, if the person is that suspicious, it's going to be very hard to get their trust most of the time. One is a procedure that I think should be a standard procedure, but a lot of people don't like the idea, is open or shared charting. I typically, when I work with somebody who has severe paranoia, I offer for them to write their own progress note and to review everything I've written and make adjustments if they think I got it wrong. And they get a copy of their file and their progress note every time I generate one. I think that kind of openness may help some people be more trusting, although it doesn't always work, of course. When people describe something to me that sounds just flat delusional and paranoid, I always have to keep in the back of my mind it might be true. And as we talk in other seminars, I'll talk to you about some stories that ended up that way. But when a person is telling me so-and-so thinks this, thus and such, and is plotting thus and such, I don't argue with the person. I ask them to explain it to me and explain it to me and tell me about it and tell me about it until they get tired of talking about it. I ask if I can help. Is there anything that I can do to help you feel safer from these entities? There's typically, not always, but typically there's usually one or two people the individual trusts. Making sure they always have access to that person will improve your stock. The idea of leveraging access to trusted people, well, if you have good behavior for today, you can go see your grandma or what have you. That is extremely counterproductive on about 100 levels, and it's especially poisonous to people who suffer from paranoia. I tend to overinform. I offer people extra literature, extra time, extra explanations, keeping in mind that very little of it may land, but I want to offer the person the idea that I am not hiding anything. Really hard not to take it personally. I'm a trustworthy person, come on. But it's good not to. And I bet y'all have all here that are here watching this have found your own ways to get there and develop at least a modicum of trust with different kinds of people you work with who have severe issues of paranoia or other reasons to not really trust any of us. So William, 82 years old, and he was referred as a cute guy with Down syndrome who likes to wear a sheriff's badge. Isn't that adorable? And I thought, that seems a little bit regressive, but okay. And sure enough, he was a very tiny man with Down syndrome, 82 years old, no dementia, by the way. For any of you that think that everybody with Down syndrome gets dementia, that's not true. He didn't have any dementia. He did have a sheriff's badge on. And they said, and well, we really don't care about that, but he doesn't sleep very well. And we're worried that if the sleep deprivation, if we can't fix that, it's going to be hard on him health-wise. Okay, I get that. Well, what about this sheriff's badge? Well, the conventional thinking in the group was, oh, well, he just wants to be the sheriff. Isn't that adorable? Well, wait a minute. Is he childlike in other ways? Well, no. He's actually kind of like a sage. Okay, so a formulation that suggests he's more of a child, that may not really fit. Let's look a little deeper. What is it that he's doing at night when he's not sleeping? He's crying. He's howling. He's saying horrific, horrific things about himself. That he's the worst person on earth. Well, let's sit down and talk about it. And so this little trait that he had, this little badge that he wore, that had been dismissed as just something adorable he'd been doing for the last 50 years, the story was much different than that. It turned out that he'd been part of an institution where the higher functioning young men had been used as enforcers to basically discipline and, in many cases, terribly abuse lower functioning people to keep them obedient. He was part of this group. They all had little vests and little badges they wore. And some of you recall there's an old word for people with Down syndrome that starts with an M, and they were called the M Mafia. And he had been punishing and torturing himself ever since. How long can a false formulation go on? We see something, we make an attribution, and let it go at that. But he showed signs of suffering. He said dreadful things about himself. He couldn't sleep. He was underweight. He didn't feel like he was deserving of good food. He was so ashamed of what had happened. And long story short, people are saying, well, he's 82. How are you going to help this? I said, well, we're going to try, aren't we? And he got proper psychotherapy. He got a chance to meet with some of the people he'd hurt and be forgiven by them. Yeah, we knew that other people were making you do it. It's okay. And at the age of 83, he stopped wearing the badge. He started wearing Hawaiian shirts and cargo shorts, started dating, and slept very well every night for the rest of his life. Understanding even the most innocuous of communications can lead us into some really, really good insights about people and give us a chance to help them in the way we'd like to. Thank you so much for attending.